then
Perfect.
that's fine. Yeah. So I'm absolutely good about that. So, all right, let's get started. So, all right. Good morning, everyone. How's everybody? Big winners? No, big losers? Okay. We won't dwell on that. How's everybody doing this morning? So, is everybody, kind of, I know yesterday was a big shock with the shooting and everything. Did anyone have to deal with any fallout from that as far as travel or hotels or anything like that? That was a awful thing. Don't get me started on gun control. So, anyway, wanted to welcome you all. I wanted to let everyone know that all the credit has been reported yesterday. All the pharmacy credit was reported to CPE Monitor. All the statements of credit for people that were due statements of credit were sent out. So if you didn't receive them and you're not a pharmacist, then let me know, please. And then I know we have a couple people who are licensed who needed reporting to CE broker, and that was done also, as long as I knew that you needed that. So if you're somebody who needs CE broker, please let me know so that we can report that. But the people that I knew about, their credit has been reported for yesterday. So same thing as yesterday. Breakfast will be up until 9 o'clock. We probably won't be breaking until, before then, but please feel free to get up, get more before it's taken off. Get up and get coffee, do whatever. Again, the water is right outside the door. If there's anything if there's anything I can do, please let me know. And does anybody have any questions for me at this point? No? Then I'm going to introduce our speaker for today, Dr. Wendy Wright. And Wendy is a doctor of nursing, a DNP, and speaks regularly around the country, has her own nursing practice, medical, practice clinic, and is, has spoken for us now. This is the second time. So welcome, Wendy. And our program today is some new drugs, a long program on new drugs, long COVID syndrome, and then postherpetic neuralgia. So,
okay, thank you so much.
Thank you. So,
well, good morning, everyone. You just heard my introduction. I have been a nurse practitioner now for 31 years, and if you're trying to figure out the math, I was 12 when I became an NP. Just so you all know. 17 years ago, after working alongside a physician for about 14 years, I decided to go out on my own, and I mortgaged my home, took out a loan from the banker, cried at the bank. She said, "I think you're going to be okay." She did psychotherapy on me. I opened that day with 7 patients, and today I have 6,500 primary care patients. I have 12 nurse practitioners that work alongside me every day. I come to you from New Hampshire, live free or die, baby. But in New Hampshire, we have had full practice authority for nurse practitioners for about 50 years. So that is my full-time job. I see patients now between 24 and 28 hours a week. And I own a medical education company and travel and speak and consult. I am the co-author of the largest pharmacology book for nurse practitioners in the nation. And where we have 70 chapters in pharmacology. So this is my baby. So let's start this morning with new drug update. What's hot and what's not. What I want to do in the course of this lecture is to really introduce all of you to these new meds that are out, how we're using them in the clinic, where are they better, or if not, are they any worse than what's already on the market? And give you a little bit of the backstory of some of these meds. I know you're all pharmacists. You know these drugs. Many of you are pharmacists. I have a few of my NP colleagues here, a few physicians, PAs, etc. But at the end of the day, it's always good to hear a little bit of the backstory of some of these meds. I have been doing this new pharmacology, this new drug lecture now for over 25 years. And Andy, there we go. What you will see is that my references are listed in the back of the lecture. They're on the end of all the slides. The last 3 or 4 slides are all the references that I use for this lecture. Here are my disclosures. I do a lot of work in the world of vaccines. That was my doctoral focus. And so you can see that these are my disclosures so that you can evaluate me and any lecture that I do for any sense of commercial bias. I am going to say to you that I'm going to be talking about new drugs. I am not here to promote any of these drugs. I'm here mainly to just let you know that they exist. Where are they fitting into the guidelines? You will hear me mention generic, brand, and then I'll go back to generic. And I know that in the world of CE, we don't usually mention branded, but when there's a new drug, a lot of us don't know what that new drug's generic name is until we become comfortable with it. So just so you know what I'm talking about. So what we're going to do is each lecture is in the vicinity of about, each new drug lecture is about 1 hour and 20-ish minutes. We'll take a 10-minute break, bring you back. We'll do part 2, and then we'll take another 10-minute break after that. I anticipate you will be out a little bit early today, but I'll shorten up the breaks a little bit so we can get you out. I want you to be able to spend your money in the casino. So I told you about the references. What's that? I'm sure they would. As I tell people, no casino is built on winners. Let me just tell you that, right? So let's talk about some new drugs. So I told you that I've been teaching this lecture for 25 years. And what happens is every January, I sit down and I look at the FDA. What did they approve this year? What drugs am I using? What am I comfortable with? And that's how I put the lecture together. But in 2022, something very interesting happened. It was one of the years where there were the least number of drugs that were actually approved by the FDA in 25 years of teaching this lecture. Now, normally the FDA approves probably 50 to 54 drugs a year. In 2022, they approved 37 only. And only 2 of those drugs actually stood any chance of making their way into primary care. Most of those drugs were rare and orphan diseases, biologics for asthma, Crohn's, ulcerative colitis, and a lot of oncology drugs. So there were only 2 that year that actually made their way into primary care. So I put the lecture together, but then what happened was in the first 5 months of 2023, 14 novel meds were actually approved by the FDA. And so it's been gangbusters since that time. So you're going to see the 2022 drugs and you'll see some of these 2023 drugs as well. So let's start out. And if you have questions for me, we've got time built in. Ask them. I'll stop at the end of each drug. Feel free to just ask away. Let's make this interactive. So what I like to do is break this out by disease state. And we're going to start first in the world of women's health. And we're going to start with this drug called ibrexafungerp. Its branded name is called Brexafemme. So it is an antifungal. And it's on the market, and it came onto the market for the acute treatment of vaginal candidiasis in postmenarchal females, so adolescents who have started their menstrual cycle, as well as adult women. After it came onto the market, approximately 6 months later, its newest indication is to reduce recurrent vaginal candidiasis. So one of the things that I'm seeing, so it's used for the prevention of yeast infections vaginally. The recommendation is to use it for up to 6 months if we're using it for the purposes of prevention. Now, one of the things that I'm seeing is that my NP colleagues, my PA physician colleagues are using this product in our patients who are on the SGLT2Is. If you're familiar with the SGLT2Is, those drugs like canagliflozin, empagliflozin, dapagliflozin, Jardiance, Farxiga, Invokana, because those drugs make you offload glucose or pee out glucose, one of the biggest side effects we see is candidiasis. So the question becomes, can I use this medicine so that I can keep these patients on those SGLT2s that are so much more now than just glucose management? Those drugs come with reduction in cardiovascular events, reduction in chronic kidney disease and end-stage kidney disease and dialysis, reduction in heart failure and heart failure hospitalizations. So they're important that we keep people on. So one of the things I have is a couple of patients who are on this medicine. They take it once a month to prevent the candidiasis that they're getting from the SGLT2I. I'll tell you, it goes against every grain in my body to give someone a drug to treat the side effects of a drug I'm already giving them. But at the end of the day, those SGLT2Is are game changers. And so that is one place that I'm using this. So we'll talk about how we use it in just a second, what the dosing is. So the way it works is it interferes or inhibits glucan synthase, which is an enzyme essential for the development of the fungal cell wall. So by blocking that enzyme, the fungal wall cannot develop and therefore cannot replicate. One of the things we are seeing in this country, just like with antimicrobials, is that we're seeing resistance of the candida to a lot of the azole products that are already on the market. Are any of you hearing this from patients? I have tried every antifungal over the counter. It's not working. Well, that's because we're seeing increasing candida resistance because of overutilization. And so this product has actually been studied and has in vitro activity against the antifungal resistant, the azole resistant strains. So we are seeing, and by the way, this is where I suspect we'll be using this product. Because of the cost of this product, where I'm positioning it is in those people with recurrent infections, and I'm also positioning it in people who have tried everything, including fluconazole, diflucan, and are saying to me, I just can't get rid of this yeast infection. So it comes available in 150 milligram tablets. The acute treatment dose is 2 pills twice a day for 1 day only. So it's 4 pills in a day, one time only. But for people who have to use it for prevention, it's the same dosing, 2 pills twice a day, 1 day only on the same day of every month for up to 6 months. So on December 1st, on January 1st, you're going to take your dose and you're going to be done for the month. The package insert says dose with or without food. My recommendation to you is I would encourage you to have the patients take it with food. The GI side effects for this product are high, not terribly high, but it's the biggest adverse events that we see. So as a result, I've found in my patients that if they take it with food, there is a little bit of less of adverse events. One of the things that happens a lot in primary care is patients call up and say, hey, I've got this yeast infection. Will you please call me in a medicine? This is not a medicine that I encourage anyone to call in without a patient being seen, particularly the patient of childbearing age. In the package insert, it states, verify pregnancy before this drug is given. If there is a chance that that woman is pregnant, this product should not be given. When studied in clinical trials, when it was given to pregnant rabbits during periods of organogenesis, those baby rabbits were born missing forelimbs. They were born with missing pinna of the ears and significant teratogenic impact. Now, granted, they were given 5 times the recommended human dose, but who the heck wants to try to figure that out on a pregnant woman?
Like you're coughing up.
At the end of the day, what we say is if we're going to prescribe this for you, and you are of childbearing age,
I think it's more than strep. I think it may have been too early to detect.
If you're negative, I can give it to you. And the other part that goes with this is women of childbearing age should be advised not to achieve or attempt conception for at least 4 days after they've taken the last dose of this medicine. Okay. We see this a lot in women in their 40s with diabetes who are on these SGLT2Is. And they're like, well, I'm in perimenopause. Well, remember, when we drop insulin resistance with any of these drugs out there, it'll often kick ovulation for these women. So it's just really important that we think about the impact of this drug on pregnancy. So to be approved by the FDA, standard double-blinded placebo-controlled trials, they studied 545 women in the clinical trials, and it was, again, double-blinded placebo-controlled. They studied 18 to 76-year-olds. So the good news is we have data in people over the age of 65. Many of you know a lot of the pharmacology trials are not done in the older adult, either because they have conditions that exclude them from trial or they're on meds that push them out of trial as well. So the good news is we see no dosing alteration in older adults, But this drug is a CYP3A4 substrate. It uses the 3A4 isoenzyme to be metabolized such that any strong 3A4 inhibitor, you need to dose reduce the ibrexafungerp by half. So I don't have a lot of patients who are taking strong 3A4 inhibitors. Those are drugs like ritonavir and nelfinavir, 2 antivirals for HIV, drugs like clarithromycin and erythromycin, or the other strong 3A4 inhibitors are itraconazole and ketoconazole. I don't write a lot of those drugs, certainly not for a long period of time. Probably the one I'm writing the most these days is ritonavir, because ritonavir is the active ingredient in ritonavir boosted nirmatrelvir. You know of that drug as Paxlovid. So if someone is on ritonavir boosted nirm, Paxlovid, and they're taking this medicine, you need to dose reduce, cut the dose in half, because remember, it's a strong inhibitor. It's going to decrease the clearance of Ibrexa by up to 80%. And you're going to increase the risk of adverse events. If they're on a strong or a moderate inducer, drug like hypericum, St. John's wort, clindamycin, rifampin, rifampin is one of them. Carbamazepine is another. It hasn't been studied. It's probably not going to harm them, but this drug probably won't work because they're going to clear Ibrexa quicker. So the biggest adverse events were GI related, diarrhea, nausea. And what I did on these slides is I gave you the drug and the placebo comparator. And you can see that while we don't statistically evaluate these drugs, we report out percentage in clinical trials. You can see that GI side effects were really the biggest adverse event. The good news is there's no evidence of any QT prolongation. That's something we certainly worry about with antifungals who are known for QT prolongation. And this does not have any evidence of that. In the clinical trials, the primary outcome was complete clinical response. That is defined as symptom resolution, as well as no evidence of candida on culture. The complete clinical response was 50 to 63%, trial 1 and 2, compared to 28 and 44% for placebo. You can see that both of those were statistically significant. So what's the downside? The downside is cost. 4 pills, if you walk in to any of your pharmacies, it's almost $500 for 4 pills. Now, obviously, people aren't going to spend $500. Remember that for your patients, that any brand new drug on the market that comes to market, if they go to the brand name of the drug.com, every one of these companies have copay cards. $0, $25 for up to a year. The problem is that our Medicare, our Medicaid, and our TRICARE patients are prohibited from using those cards per federal regulation. So the people who often need them the most can't use those buy down cards. But I encourage people to go to that or GoodRx cards. But oftentimes those pharmaceutical copay cards, their whole goal is to get us using them to try out these products. They're often $0 to $25. And I've seen these for $25. Now, in October of this year, you may have seen this for those of you working in pharmacy, you may have seen that there's been a temporary disruption in the ability to get Ibrexa. And that was because there was cross-contamination with a beta-lactamase somehow in the production process. Beta-lactamase antimicrobial got into the manufacturing process for this product. And so as a result, they were concerned that it would cause severe allergic reactions. They shut down that production, that arm of the production company, and it did impact availability. It's slowly starting to come back, but it's been tougher to get, and it's been on back order in some pharmacies. Questions for me on ibrexafungerp or comments? Any of you seeing it being used? Pharmacies? Prescribers? No? Okay. Let's go to neurology. And this is where I want to start with a backstory. The first drug I'm going to talk about has been deemed the most controversial approval by the FDA ever in the history of the FDA. I'm not sure that that's the truth, but it's a pretty controversial approval. So the first drug I'm going to talk about is a drug called aducanumab. Its brand name is called Aduhelm. So let's talk about this. So this is a drug. It is a monoclonal antibody, and it is an amyloid beta-directed antibody, which has been shown to reduce the development and the laying down of beta amyloid plaques in the brain and the central nervous system. So this is a drug that we are giving to people who have mild dementia as a result of Alzheimer's, because we know that beta amyloid plaque deposition is the key cause or driver of Alzheimer's dementia. So this product has now been fast-tracked by the FDA for approximately 2 years. Remember what a fast-track designation is. It's similar to what you saw in the COVID pandemic, where a lot of the vaccines were originally EUA, emergency use authorized. The purpose was, let's get these out on the market. You continue your clinical trials while we've got these products out on the market, because we think it's important to get it out before all these trials are completed. So that's what happened with aducanumab. It was fast-track designated to get this product out onto the market. Remember that anytime you see a drug that ends in mab, it means expensive. Okay, so if you just remember that, it's going to be expensive. I did this program about 3 weeks ago or so, and one of my evaluations said, this was such a good program. That are covered or non-expensive. And I thought, well, that just about eliminated my program, right? Because when a new drug comes to market, you know it's not going to be covered because they have to negotiate contracting with the PBMs, et cetera. And you know that they're going to be expensive. Does anyone have any sense of how much money it costs to bring a drug to market in the United States? So if I'm a pharmaceutical company and I want to bring a drug to market, what's the cost? Anyone have an idea? $2 billion in the US. $2 billion. So obviously, they're going to want to make the money back, right? They're only going to invest in those products that they think they can get money back. So, and I understand that welcome to capitalism. They also say that if you can make it here in the US and you can get through the FDA in the US, you can become a drug in any part of the world, because the US FDA is the most conservative, is what people will say. So this is an IV infused drug. This is not going to be something that will be dispensed at the pharmacy. This is an IV infused drug, and it is infused at least every 21 days. So most folks are doing this once a month. We start at 1 milligram per kilo over an hour. We then go up to 3, up to 6, and up to 10. The recommendation is 10 milligrams per kilo, and I'll show you the clinical trials that show that 10 milligram dose, it has the best efficacy. From a beta amyloid plaque reduction, that 10 milligram dose once a month for the rest of their lives or until their disease doesn't warrant them continuing on this med is what the recommendation is. But before they start on this medicine, they need an MRI. It has to be done within the year prior to starting on this med. Then they need another MRI at month 6 after their 6th infusion. Why? Because if you go back here at the 6th infusion is when we're then going to go up to that 10 milligram or that maximum dose. So they need an MRI before they go up to that maximum dose. And then they need another MRI 6 months after being on that maximum dose. So what's the deal with these MRIs? The deal is this class of drug is associated with what's called ARIA. That stands for amyloid-related imaging abnormalities. ARIA, amyloid-related imaging abnormalities. So, and the radiologists have now been trained. This is the abnormality that warrants stopping this drug. This is the abnormality that warrants holding in the dose. This is the abnormality that warrants stopping. And it's all based on symptoms, but also based on MRI. So before you ask me, are these MRIs being covered by Medicare? They are being paid for by Medicare. But just like every other Medicare or commercial plan, there is the potential that there will be patient responsibility due to deductible. Would you all agree, though, that most patients with dementia are probably on Medicare? Most patients with Alzheimer's. So Medicare often has that 10% coinsurance. So there will be some patient responsibility. So essentially, these patients are going to have 3 MRIs in the first year of being on this drug. So let's take a look from one study, the amyloid beta plaques as identified on PET scanning. So if you take a look at this top line here, this is an 79, 80 week trial. You can see that amyloid beta plaques as monitored by MRI PET, you can see that the amyloid beta plaques in the person who got placebo, the people who got placebo, and there were about 159 in the trial, their beta amyloid plaques increased over time. For the patients who were started on the drug, you see within weeks, there is a decline in beta amyloid plaques. And that top line is the patient who stayed on the 6 milligram dose. That steeper dotted checkered line is the person who got to 10 milligrams. So that 10 milligram dose from an amyloid perspective is clearly better than the 6 milligram or placebo. That's great. That's what we want to see. But here's the question. That's all well and good. That's what happens from a pathophysiologic perspective. But what does it mean clinically? Does this drug improve clinical outcomes? And so that's really where the rubber meets the road. How many of you remember the day we used to put people on high dose niacin? Any of you remember this? We used to say high dose niacin, 2 grams a day. It's going to make your HDL go up and your triglycerides go down. And by the way, they ripped their clothes off because they were flushing so much. They were so miserable, but we're like, hang in there. We think it's good for your lipids. What did we find out? 3 pivotal trials. It was useless. While it may raise HDL and lower triglycerides, there was no improved clinical outcome whatsoever. That's why niacin or niaspan is no longer recommended in the lipid guidelines by the American Heart Association. Yes, it did from a laboratory perspective what we thought it would do, but it didn't improve clinical outcomes. So what about this product? Here is study 1. And in this study, they did all kinds of functional scores. They did things like the mini mental status exam, the ADAS-Cog, and a variety of other functional scores. And you can see that in this study, the mini mental status, the ADAS-Cog, I've given you the p-values. Many of them were fairly statistically significant. So that's great. That's study 1. The problem is in study 2, they didn't see statistical significance in some of the functional scales. So we've got a drug that we know reduces beta amyloid plaques, but in one study, we see some decent results clinically. And in this other study, we didn't. But here is also where there's concern. So I mentioned ARIA, amyloid-related, imaging-related abnormalities. There are 2 of them. The first one is ARIA-E, that stands for edema. The second is ARIA-H, that stands for hemosiderin. Well, it's one thing, folks, if you've got diarrhea from your drug. It's another if you've got edema in the brain or if you've got hemosiderin. Because if you've got hemosiderin deposition in the brain, it means you've had microvascular bleeds. You've had microscopic bleeds. So how common were they? 41% of patients who were treated with a 10 milligram dose had ARIA-related imaging abnormalities, and about 10% had placebo. Now, the majority of people, those adverse events were mild, but that's a little disconcerting, right? These are pretty scary adverse events. I've given you here how they all played out. Edema was the most common at 35%. Some of it was mild, but some of it was serious swelling in the brain. And then you kind of go down from here, the microhemorrhaging, falls, diarrhea, altered mental status. So here's what happened. This drug came to the market and everyone said, first to class, blockbuster drug. This drug is single-handedly going to shape the future of patients with Alzheimer's. They launched at $58,000 a year. So $58,000 a year, conceivably being on it for the rest of their lives. The CMS director came out and issued a statement and said, if everyone in America who is eligible for this drug goes on to this drug alone will single-handedly bankrupt the Medicare system. Because it was fast-tracked only, Medicare said, we do not believe that while we believe that this drug has merit, we do not believe at this time that this drug is something that we will cover. So for the first year of this drug, it was out. No one was writing it. Because if Medicare is not going to cover it, who's going to pay for it, right? And so Medicare said, we will cover it if you're in a clinical trial to further study this drug, but for routine patients, we're not going to cover it. Well, I have 2 patients in my clinic who are in their 50s with early onset dementia. I sent both of them to Dartmouth-Hitchcock, our tertiary center in New Hampshire, and they came back to me, both of them, and neurology had said, I'm sorry, we're not prescribing this. Both of them were on commercial insurance, but they said, we do not feel comfortable with these adverse events. And their insurers are not covering it either, because where Medicare goes, so too does everyone else. So I think it's Biogen or Johnson & Johnson Biogen who was making this. They cut the cost down to $28,000 a year and to try to spur the use. Medicare in April of this year reversed their statement. They came out in April of this year and said, we will now cover this class of medication if it is fully FDA approved. Whatever the FDA says the indication is, when they give it a full approval, is what we will pay for in Medicare. The FDA has yet to approve this drug. So this drug is pretty much not being used other than in clinical trials because it's still not being covered. What then happened was Eisai launched their new drug called lecanemab. It's being sold as Leqembi. This is also a monoclonal antibody. This is also indicated for mild Alzheimer's dementia, but their indication expanded it even further, and their indication includes mild cognitive impairment. For all of us in clinical practice, you know that it's next to impossible to discern, is this MCI versus early dementia? What tells us which one it is if these people progress or not. Not everyone with MCI will ever progress on to dementia, but some will. So it's indicated only in the early stages, MCI and mild dementia. Again, a monoclonal antibody. And this product is also an infused product, but what's different, everyone, is with Leqembi, it's every 2 weeks. So instead of going in once a month, these families are having to transport their family member every 2 weeks for the rest of their lives for this infusion. It's again, IV infusion. It's also a 10 milligram dose. Here's one of the studies for you again, PET scanning. Here's your placebo in the top, and here's your 10 milligram dose. And you can see that there is a reduction in beta amyloid plaques. What was seen in their trial, in both of their studies, they did a number of functional scales, and they showed statistical significance in all of their functional scales in study 1 and study 2. One example, ADAS-Cog, the baseline score, and they followed these people for 18 months on this infusion every 2 weeks. And they saw that patients who got the drug, their ADAS-Cog ended up 4.14. The placebo was 5.5. The higher the number, the worse the dementia. So you want it lower. And here's your p-value, very statistically significant. So what happened was, even though this was second drug to market, it is now fully FDA approved. And because it is fully FDA approved, Medicare is now covering Leqembi, but not covering aducanumab. And they, again, have the same MRIs, requirements, a little bit different, but prior to the 5th, 7th, and 14th infusions. And they also have the same ARIA abnormalities, but they did appear to be slightly less in the lecanemab trials than what we saw in the aducanumab, but there's no head-to-head trials. Just numbers alone look to be a little bit less. So what are we seeing? I typed this out for you so you could see this, but 3% of patients had symptomatic ARIA in in study 2. So that was 29 out of 900 patients, roughly. And serious ARIA was somewhere around 6 out of 898. 80% resolved all their symptoms. And study 1, the observations were pretty identical. So I just wanted you to see that the adverse events continue in this class of medication. But what's been really great is we've learned a lot now that these products are out here, and here's what we've learned. We've learned that patients who test positive for APOE4 allele and are what we call homozygotes, those individuals are the ones that we generally see the ARIA complications in. So this is a blood test that we can actually run on newborns. And if you are APOE4 allele positive, you are at an increased risk for the development of Alzheimer's. And we've known that for years. People have said to me, should I get that test? Well, what are we going to do about it? If you have that blood test and you're positive for it, it means you're at an increased risk, but we have nothing available to stop it from happening. So why worry your entire life that you're going to develop it? But we do know that people that are APOE4 allele positive tend to have an earlier onset to their dementia. So this is now a blood test that before people are started on any of the MAB products, that this test is run. If they're a homozygote, they have a higher rate of ARIA adverse events compared to a heterozygote or someone who tests negative for APOE4 allele. So providers are now doing genetic counseling prior to starting on this product, getting this blood test so that they can provide patients with information about whether they're at risk for these adverse events or not. So because it is the first FDA fully approved drug, this is the one that your patients have access to now if they are on Medicare, and a lot of the commercial plans have followed. Questions for me on the monoclonal antibodies? Okay.
How long can they stay on instead of going good for a short time?
Yeah. So the question is, how long can they stay on? The studies were done for 80 weeks, but there are now patients who have been on these for 2 and 3 years. So they can stay on indefinitely, as long as they're not having adverse events and as long as their life quality warrants continued infusion. We've never had anything to really impact the pathophysiology of the disease. What we've done is we've treated people with your cholinesterase inhibitors. We've treated people with the NMDA receptor products like memantine, but all those did was kind of like a Band-Aid. This is a drug that really impacts pathophysiology. What happens when they stop it? They're going to progress. Yeah. And so we're going to see people on this indefinitely. This is the future. And I don't know if you've had patients come in and talk to you about this. There's now a blood test that we can do right through LabCorp Mayo Quest that looks to see if patients have beta amyloid plaques in their body developing. So that's one of the things that we're now doing as we're working people up for dementia, is we're looking for the presence in a simple blood test. Do I have beta amyloid plaques that are there and developing? We've come a long way in the world of dementia, which is great, but these drugs are not cheap. All right, let's go to migraine. So I remember 35 years ago training on the drug called sumatriptan, Imitrex. And I remember in that training learning that one of the key drivers of migraine is a peptide called CGRP. That stands for calcitonin gene-related peptide. Is there anyone in this room who has migraine headaches? Okay. So if you don't have one yet, give me a few hours. You'll probably have one by the time I'm done. Just kidding you. But let's say you don't have a migraine now. I hook up an IV in your arm and I infuse CGRP into your vein. It will trigger a migraine, hands down, almost 100% of the time. So we know that this calcitonin gene-related peptide is an inflammatory mediator that causes vasodilatation of the cranial blood vessels. So if we can find a way to block CGRP, both acutely as well as chronically, we can prevent migraine and we can treat them acutely. The problem was they worked for about 30 years to find a drug that they could bring to market that didn't elevate liver enzymes. The initial CGRP antagonists had a lot of liver enzyme issues. These newer agents do not. And I will tell you that this class of medication is the future of migraine, both acutely as well as prophylactically. And I don't know if you've had patients on drugs like ubrogepant, Ubrelvy, rimegepant, Nurtec, or if you've had patients on drugs like Emgality, Ajovy, Aimovig. These drugs are game changers for people. They single-handedly can transform patients' lives. And I've seen it in my clinic within a month of an injection with an Aimovig, Emgality. So these drugs, patients are saying to me, my headaches are down by 50, 75%. It's really a game changer. So this is the newest product, zavegepant. So Gepant is a CGRP antagonist. It ends in Gepant. This is the first nasal spray that is a CGRP antagonist. Well, in America, Americans do not like nasal sprays, nor do they like rectal suppositories. So to get people to use this drug is probably, you're not going to see it used very often. Where I'm positioning this nasal spray is in a person who has a rapid onset of migraine and a rapid escalation of it. Or people who wake up in the morning and they're already in the midst of a full-blown migraine. Because this drug is delivered through the nasal mucosa and absorbed through the nasal mucosa, it bypasses some of that first phase of absorption in the gut. And remember, patients with migraine often have gastroparesis during their migraine, which often affects the absorption of a lot of their oral medications. So I'm using this in the woman or the male who says to me, my migraines occur always first thing in the morning. I wake up and I'm already in the midst of a migraine. That's a person who could benefit from a nasal spray. Other than that, I'm not really using this, but it is now available. So it's indicated only for adults. By the way, that is true with all of the CGRPs. None of them today are indicated for kids. We suspect at some point they will. There are studies underway, but these are for 18 and up. This is a 10 milligram dose, one spray into one nostril once a day as needed for acute migraine. So there's no ability to repeat this. It's one spray over a 24-hour period. The FDA determines what the primary endpoints are, and the primary endpoints in all the migraine studies are pain freedom at hour 2. That means they have zero pain, and freedom from their most bothersome symptom. So in the clinical trials, patients are asked to identify what is your most bothersome symptom. Nausea, vomiting, photo, or phonophobia are the 4 choices. And then at 2 hours, what % of those patients became free from that most bothersome symptom? So what you're seeing here, 2 double-blinded placebo-controlled trials, 600 or so patients in each arm. First number is the drug, 23%, no pain at 2 hours. Placebo is your next report out, 14%. Freedom from their most bothersome symptom, 39 and 31. Study 2 was very similar, and both of those were statistically significant. They also looked at secondary endpoints, pain relief, so people who got not freedom from pain, but got down to a 0 to 1. And they also looked at return to function within and sustained pain freedom. And all of those were statistically significant, hence the FDA approval. The biggest side effect, as you can imagine, with a nasal spray is taste disturbance, dysgeusia. And we see this a lot with drugs like topiramate, where people will tell you drinking soda tastes like I'm drinking a mailbox. I don't know if you've ever had people say that to you. The other drug we see a lot of taste disturbance or dysgeusia with is Paxlovid. A lot of taste disturbance with that as well. So this is about 18%. Two little pearls for you all in terms of this nasal spray, any nasal spray. Here's what I teach my patients. Keep your nose over your toes. Don't tip your head back. You tip your head back, it drains down the back of your throat. Keep your nose over your toes and let the extra come out in a Kleenex. Rule 1. Second, opposite hand sprays the opposite nair. So if you're going to spray the left nair, you use the right hand and vice versa. That way the spray goes up into the turbinates and not onto the septum. We see a lot of epistaxis with nasal sprays, and a lot of it is because they're spraying it on the septum, which is highly vascular. So that is our biggest side effect we see, about 4% with nausea. And then the other side effects are nasal discomfort and vomiting. The good news is there are no significant drug-to-drug interactions with one exception, and that is intranasal decongestants. So if a patient is using neosynephrine, Afrin, they should separate it apart by at least an hour. If they're going to use the decongestant, they want to use 1 hour or more after they use zavegepant. Otherwise, that's really the only interaction we see. And the only real big adverse event that we see is bankruptcy. Just kidding. This is $1,000 for 6 sprays if you walk in and you pay cash. This is also a drug, by the way, every CGRP should never be used in pregnancy. And in fact, most experts will tell you they want women off of CGRP antagonists at least 3 to 4 months before they attempt conception, because CGRP has some impact in uterine contractions and may have some impact on the baby. So we want to make sure that this patient is not pregnant. It is not approved in kids. We don't want to use in severe kidney disease and, with severe liver disease, that is. And we don't want to use it in severe kidney disease or someone with a creatinine clearance of under 30 mLs a minute. By the way, one of the things we see kind of across the board is once someone's creatinine clearance drops below 30 mLs a minute, a lot of the drugs we use in primary care are offloaded. We still have to start to take people off. The statins is one example. The bisphosphonates are another. That 30 mLs a minute is critical. One of the things we do in our clinic is when we see a patient for their welcome to Medicare exam, we calculate out their creatinine clearance and we set it as a reminder in the chart. That is a signal to the NP that comes after us. You need to look at their kidney function. I have a woman who's 102. Her creatinine is 0.8. Her creatinine clearance is 18 mLs a minute because she weighs 100 pounds soaking wet. And her creatinine clearance is abysmal. A lot of people don't look at kidney function as adequately as they need to before they're prescribing a lot of these drugs in the older adult. It's pretty scary, actually, particularly antibiotics that have such renal impact. A lot of people don't even think to look at kidney function. So this is true with a lot of drugs. Creatinine clearance is a big player. Now, continuing on in the CGRP class, we're now going to talk about atogepant. This is sold as Qulipta. The difference from zavegepant to atogepant is for prevention. So this is a product that patients are going to take once a day for the prevention of migraine. When it first came out on the market, its first indication was episodic migraine. That's actually defined as less than 15 migraine days in a month. Its newest indication is chronic migraine. That is defined as 15 or more days a month, and that is not on your handout. So so this essentially can be used in any patient with migraine less than 15 or 15 or more days per month. And by the way, in the world of migraine, we are no longer saying to patients, how many migraines do you have a month? What we're saying is, how many days of the month are you impacted by migraine? Because I have patients in my clinic who have 1 migraine a month. but it's 7 days. So that's 7 days of migraine. The reason that this is important is the American Headache Society says any patient with 2 migraine days a month and severe disability warrants a prophylactic medication. So this class is truly the first class of migraine prophylactic meds that were studied to target the underlying issue of migraine. Most of the migraine prophylactic drugs we use are antihypertensives or antiepileptics that, oh, by the way, can reduce migraine. But they also come with significant side effects for a lot of patients. There are 3 doses, 10, 30, and 60. It should be dosed with or without food. For your patients, you want to get most of them to 30 and 60 milligrams. The 30 and 60 are truly the dosages where we see the best reduction in migraine frequency or the number of monthly migraine days. And for people with chronic daily migraine, 15 or more migraine days a month, 60 milligrams is the dose we want them to be on. So why do they make the 10 milligrams? Because this is also a CYP3A4 substrate. So if patients are on strong 3A4 inhibitors, the dose is 10 milligrams of atogepant because they're not going to clear it as well. If they're on strong or moderate inducers, they're going to clear this drug quicker. So you want to get them to 60 milligrams if at all possible. And this drug can be used in severe renal impairment, a creatinine clearance of under 30 mLs, but the maximum dose here is 10 milligrams once a day. So how efficacious was it? I just grabbed one study just so you can have a sense. They studied about 2,000 patients, double-blinded placebo-controlled trials. The patients were allowed to stay on all their other controller drugs, and they were allowed to use all of their other medicines, their acute medicines, except they couldn't be on any other CGRP because it would mitigate the results or it would impact the results. And they looked at multiple measures. I just grabbed one study. So what you're seeing are the different dosages across the top. Placebo is on the right side of this table. What you're seeing here is the number of monthly migraine days that the patients averaged. And you can see that they averaged someplace between 7 and 8 monthly migraine days. That's pretty normal for most migraine studies. You can see that at 12 weeks in the placebo arm, monthly migraine days went down by 2.5 days. Why? Because they were being monitored. They had electronic diaries. They were given dietary instructions, foods to avoid, and they were being monitored. So we know that there's always some degree of placebo response. But take a look at that 60 milligram dose. Essentially, the 60 milligram dose cut the days that they have migraine in half, a little over 50% reduction. And in some people, there were 75 and 100% reduction in monthly migraine days. Statistically significant. You can see the numbers here. And so when I tell you that this class is really the future, I really believe it is. The only thing that I do want you to know is GI side effects, nausea, constipation are the most common adverse events. But what's now being reported out in post-marketing trials is that about 4% of patients who go on this drug have unexplained weight loss. Now, for most Americans, they'll be happy with that. But in our world, unexplained weight loss is a malignancy until we prove it otherwise, right? And that weight loss is coming in somewhere around 5% weight reduction. We do not know why that weight reduction happens or that unexplained weight loss occurs. But if you have patients come in and say to you, after I started on this drug, I'm losing some weight, be aware that there is post-marketing information, and there are studies that are due to be presented in Q1 on possible the reasons, the mechanism why this is occurring, but just be aware that it is being reported out. And again, we do not want people who are pregnant or lactating to use any CGRP drug. This product is $1,000 for 30 pills if they pay cash. Again, go to the brand of any drug. Copay cards exist. I know that there are copay cards for $0 a month for patients on commercial plans. Questions for me on CGRP medicines and migraine? You doing okay? Yeah? Okay. Pharmacology at 8 a.m. I know many of you are pharmacists. This is your life. But for us NPs, buckle up, right? Hold tight. So let's talk about the next medicine, daridorexant. Daridorexant, so it ends in rexant. It means it's an orexin antagonist. So I told you I've been an NP for 31 years. In 1992, when I was in graduate school and graduating, we didn't even learn about orexin antagonists because we had no idea that orexin even existed in the brain. So orexin is a neurotransmitter that causes the release of a number of other neurotransmitters that drive our wakefulness. It's what at 6 o'clock in the morning, or if you're from the East Coast like me, at 4 a.m. this morning said, oh, it's time to get up. That is orexin. That is part of what governs our wakefulness center. So this is third to market in a class that came out about 10 years ago. It was in the mid-90s that they actually discovered orexin. And the first one to come out was a drug called suvorexant, Belsomra. Heard of it? Okay. Second one was lemborexant, Dayvigo. And this is third to market, daridorexant. So what I tell patients is this. The way this class works is instead of turning on your sleep center, which is what the hypnotics do, the Z drugs, the zolpidem, zaleplans, this drug turns off your wakefulness center. None of these drugs are on the Beers criteria. So when I've got an older adult and I want to use a product that is not on the Beers criteria, I don't have a lot of options for sleep. I have the orexin antagonists, the three of them, and the other drug I have is doxepin. Doxepin under 6 milligrams, sold as Silenor, is not on the Beers criteria. Once you get 6 and above, then it's on the Beers criteria. So those are the only drugs we really have in the older adult that are not on the Beers criteria. If I could design a sleep algorithm, and if the folks at the sleep medicine agent organizations ask me my opinion, what I would do for sleep is CBTI involved in every guideline, which is all about counseling to sleep consolidate, sleep restrict, good sleep hygiene. I think that should be included. But trying to find someone who can do CBTI is pretty tough and it's expensive. But I would also include the orexin antagonists as my first line drugs because they're not on the Beers criteria and none of these drugs are linked with increase in falls and fractures in the older adult. I think, in my opinion, they are the safest of all of them. There is no indication that these drugs are also linked with dementia, like many of the benzodiazepines, the GABA-based drugs, and the other hypnotics are. So what is this indicated for? It's indicated for sleep onset as well as sleep maintenance. So it can be used for those people who have difficulty falling asleep and those people who have difficulty staying asleep. It is a 25 and 50 milligram dose. However, the FDA said there is no dosing titration schedule. If you want to start a patient on 50 milligrams out of the gate, you can. And my pearl to you is you should. The 50 milligram dose is the dose that was found to be the most effective in onset and maintenance, but it was also the dose. And by the way, this drug was the first drug that ever studied daytime sleepiness as a result of giving people a drug to make them sleep. And what they found was people who took the 50 milligram dose had less daytime sleepiness than people who took the 25 or people who took placebo. That means that people are getting better sleep and that this drug does not have a carryover effect. It has a half-life of 8 hours, designed to mimic a normal sleep cycle. And it reduced the amount of time that it took people to fall asleep by 30 minutes. By the way, what's a normal amount of time it should take people to fall asleep? What's our goal? Under 30 minutes. What's the amount of time we want people to be awake in the middle of the night? Under 30 minutes. How much is the average adult? What's a good amount of sleep for the average adult? 7 to 8 hours. How much time that you're laying in bed should you be asleep? It's called sleep efficiency. What percentage? 85%. So a lot of the work I do in primary care is educating people about what is an acceptable night of sleep. Because people come into me and say, I don't sleep like I slept when I was a baby. No, you don't. No, you don't. First of all, you work, your brain is processing. But as we get older, we move through phases quicker, which means we tend to move through our phases quicker. We also tend to have what we call phase advancement. As you've gotten older, do you want to go to bed at 7 and 8 o'clock at night? Many of us do. I say to my husband, my ideal schedule would be to eat dinner at 4 o'clock. I call it the blue light special. That's me. And I want to be in bed by 8 o'clock at night, particularly now that the time has changed. That happens as we get older. So a lot of the work I do in primary care is to say, it's not unusual to wake up at night. Are you able to get back to sleep? Do you feel okay the next morning? And if you do, I don't need to treat your insomnia. That's not insomnia. That is normal sleep behavior. But people are convinced that they want to lay down and not move. And the only people that do that are teenagers, right? I used to say to my son, he was the worst sleeper as a baby, the worst sleeper. And then he became a teen and he wouldn't move for 12 hours. I'm not kidding you. I used to say to him, your bladder must be like a camel. How do you lay there for 12 hours and not move? But he did. And so this drug, the average time it took to fall asleep when they entered the trial was 60 minutes. It cut it to 30. That's where we want it. The average time they were awake in the middle of the night was about 1.5 hours. It reduced that to reduced it by 60 minutes. And they had a reduction in their daytime sleepiness. Now, one thing for you to take away about this class of medication is that this class is not a medicine that they can take as needed. It doesn't work. The orexin antagonists do not work well as an as-needed drug. These are drugs that are really meant to be taken every night. And by the way, the people in the clinical trial had insomnia, chronic insomnia for over 10 years. So these are people who just every night know they're not going to sleep. And it must be horrible. One thing I do tell my patients is the longer you stay on this, in the clinical trials, we saw continued significant improvement over the course of a year. So biggest side effect, headache. Placebo was 5, 6, and 7%. Fatigue 2 and 3 versus 1. Little bit of nausea at that 50 milligram dose. That's the 3% there. But people really do tolerate this fairly well. I do want you to cross out this VitaCare. That is because this drug is now available in commercial pharmacies. When it first came to market, it was approved in May of 2022. When a drug comes to market mid-year, there isn't an insurance company, PBM, that's going to cover it. So the way they got it to patients was through a specialty pharmacy, buying down the cost of the drug, shipping it out to patients. Now it's available in the local pharmacies. Questions from me on daridorexant. By the way, its sister drug, suvorexant, is now approved for insomnia related to Alzheimer's dementia. So we are using Belsomra in patients with Alzheimer's dementia who have insomnia. Let's go to cardiology. And let's talk about this drug called inclisiran. Inclisiran is an injection for patients to be added on to a statin in patients who have atherosclerotic disease, in patients who have a familial hypercholesterolemia, or in people who are unable to tolerate statins. So generally, you're not going to see that this injection is going to be used for your run-of-the-mill person who needs a lipid reduction. This is for the most recalcitrant patients. So some of you may remember it was around 2018 that the American Heart Association, American College of Cardiology, came out and said, we're no longer treating to an LDL number. put them on a moderate intensity, put them on a high intensity statin. And if they're on the statin intensity commensurate with their diagnosis, you call it a day. Well, in the 2022 update, American Heart, American College of Cardiology, and the ADA, they now say, we want to treat to an LDL goal again. Now, we want patients who have atherosclerotic cardiovascular disease to have their LDLs reduced below 55. We want patients who have diabetes and lipid disorder to have their LDL under 70. I have a patient in my clinic whose LDL is 400 off medication. She had a stent at 36 years of age. These are people who are making LDL. Their LDL receptors on the liver are not binding LDL, and they're not clearing it. By the way, studies in familial hypercholesterolemia show that at the age of 2, babies are already developing lipid plaques in their carotids. This does not bode well for them as adults. So this is a drug that we are adding on, and it's competing with what are called the PCSK9s. You know of those drugs as alirocumab, drugs like Praluent, and evolocumab, Repatha. Y'all familiar with those? Okay. So here's how the PCSK9s work. On our liver, we have LDL receptors. It's the job of those receptors to bind LDL, break it down, clear it from the body through the feces. But we've got this enzyme in our body called PCSK9 that degrades those LDL receptors, breaks them down, making them unavailable to bind LDL. That's why the LDL is so high in the body. We eat about 20% of our LDL. We make the rest. So when we put people on statins, all they do is block the production of LDL. They're going to lower LDL 40, 50%-ish. But when we put people on drugs like alirocumab and evolocumab, Repatha, and Praluent, what they do is they block the PCSK9 from degrading those receptors, and we can lower LDL by 60 to 70% with those PCSK9s. So how does this drug, which is called a small interfering RNA, how does it work? It blocks the PCSK9 enzyme from ever forming. So it's actually one step before the PCSK9s. So we're either going to use this drug or we're going to use the PCSK9s. Why are we using PCSK9s? Because they've been out on the market longer and because they have outcome trials. We do not have any outcome trials on inclisiran yet. So we know it lowers LDL. What does it do cardiovascularly? We don't know. Those studies are due to report out in early 2024. And once we see outcome trials, I suspect we'll be using this a lot more. With the PCSK9s, people have to self-inject subcutaneously every 2 weeks for the rest of their lives. This is going to be an every 6-month subcutaneous injection that is going to be given in our offices. So they'll come in every 6 months and we'll give them a 284 milligram subcutaneous injection. I expect that after we get comfortable with this drug, we see how people are doing with it. Because it's subcutaneous, I suspect we're going to see it'll come as an auto injector and people will be able to do this all on their own every 6 months at home. But as of right now, FDA wants it given in our clinic. So we give them a loading dose. We give them a loading dose on day 0. We bring them back at day 3 months to give them their second dose. And then after that, it's an every 6-month injection. So to give you a sense of what this drug is capable of, when added on in patients with hyperlipidemia who already have atherosclerotic cardiovascular disease, and they're already on a maximally tolerated statin, whatever dose they can tolerate, whatever intensity they can tolerate, it reduced LDL an additional 51%. It also reduced ApoB, which is an atherogenic LDL particle, very atherogenic. It's small, it's dense, and it's able to cross easily through the endothelium, lay down a lipid plaque. It's a bad actor, 45% reduction What does it do cardiovascular wise? We don't know, but we will have that data next quarter. So they studied 1,800 patients. You can see that about 67% of patients were 65 and older. So this is a drug that has been evaluated in our older adults, which is great. And there were no differences in safety nor efficacy in the older adult. The biggest side effect, it was really well tolerated, actually. If any of you have worked with patients on the MAB products, they will tell you that they ache. They have flu-like symptoms often after they give themselves that injection. What we saw here was injection site reaction. 8% was the biggest adverse event. We are not going to treat anyone for a lipid disorder who's pregnant or lactating. It hasn't been studied in pediatric patients, hasn't been studied in severe liver or kidney disease. It's $6,000 a year. That is exactly the same cost as the PCSK9s. Those are about $6,000 a year as well. So again, I know it's ridiculously expensive, but one night with an MI is very expensive as well. So PCSK9s have been shown to lower cardiac events within 18 months by 48%. So pretty amazing results. I also get asked, how low is too low with LDL? Do any of you remember the day we used to say we don't want to go below 40? When we take people's LDL below 40, they start to develop paresthesias. No longer. The PCSK9 trials are now getting people down into the 20s for their LDL, and they're continuing to see significant reduction in cardiac events the lower they bring their LDL down. By the way, what were you born with? What was your LDL at birth? 40. What was your A1C at birth? 4.5%. So if that doesn't give you a sense of what we eat and what our lifestyle does, right? Because that is what is factoring into a lot of our LDL and a lot of our A1C. Any questions for me on, oh, yeah, go ahead. They want it. So the question is about why the clinic, they want us monitoring for anaphylaxis, because the MABs traditionally, many of them have warnings regarding anaphylaxis. So they want us monitoring people, getting some history with the drug. And then I suspect the one that comes to mind is the drug called omalizumab, which is known as Xolair. Xolair, we've been giving out now, for a decade at least. And people always had to, every 2 to 6 weeks, go to allergy, immunology to get those injections. Now they're subcutaneously administered at home. I think it's just, let us figure out how people are reacting and then we'll move it to the home. This will likely, so as of today, inclisiran is not in any of your pharmacies. We have to purchase it through a specialty pharmacy, give it to the patient, and then pray that their insurance pays for it. So I don't think you're going to see inclisiran in primary care. I think you're going to see it in places like lipid clinics, hospital systems that can carry $3,000 in drug supply. All right, let's go to finerenone. I want you to know about finerenone. Anyone seeing this being dispensed or written yet in your pharmacies? Okay, I want you to know about this because it's now part of the ADA guideline. And it's part of the American Diabetes Guideline for patients with type 2 diabetes who have chronic kidney disease, who are already on standard of care for their kidney disease in order to reduce end-stage kidney. Look at this broad indication. To reduce sustained EGFR decline, end-stage kidney disease, cardiovascular death, non-fatal MIs, hospitalization for heart failure. So this is a drug that has now been shown, like the SGLT2s and the GLP-1s, to not only help to slow progression of kidney disease, but also reducing MIs and heart failure. So this is a drug that really belongs in primary care. But as of today, who's writing it? Nephrology. My nephrology colleagues are writing this like crazy because they are the ones who are seeing these patients who have kidney disease, have diabetes, and we know that these are the patients who end up on dialysis. Friend of mine runs a nephrology center in Charlotte, North Carolina, and she says her quote is always, "A day for a patient who with diabetes who's not on dialysis is a really good day," right? If we can keep these patients off of dialysis. So look at the ending of the drug. OWN, it's coming onto the market. It's an MRA. It's a mineralocorticoid receptor antagonist. So it's coming onto the market to compete with spironolactone and eplerenone. But what's different is many of you see and many of you write spironolactone for PCOS, right? Because doesn't it block androgen? It's a steroidal mineralocorticoid receptor antagonist. This is a non-steroidal. So this product is never going to be a drug we're going to write for a woman with PCOS to block androgen and help with hirsutism. I have a lot of patients in my clinic, male to female, transgender, transitioning patients. We have those patients, male, female, on high dose spironolactone. It blocks androgen. They develop gynecomastia. Their testicles shrink. That is the purpose for using spironolactone in the male to female transitioning patient. So this is not going to be a drug that you'll use there because it has no affinity for androgen whatsoever. It works on the mineralocorticoid receptors that are located in both the kidney as well as the heart and other blood vessels. So type 2 diabetes and kidney disease is the person that will get this drug. Now, first line therapy for those patients is a RAS inhibitor, a renin angiotensin aldosterone antagonist. ACEs, ARBs are where we're going to start. Then we often go to an SGLT2 at that point. This is going to be a third line drug probably, or first line in people who can't take an SGLT2I. So what dose we get them to is dependent upon their GFR and their potassium. We start at 10 milligrams a day usually, although if their GFR is 60 or greater, we can start at 20 milligrams. And 20, by the way, is the dose we want to get people to. It's the maximum dose. Now, I have people say to me, if their GFR is over 60, why are we putting them on a drug for kidney disease? Remember, a normal GFR is 90 to 120. But the problem is many of our labs never reported it out until it dropped below 60, right? So we often didn't know people had kidney disease until we got to stage 3A, which is a GFR of under 60. The other thing that's now in the ADA guidelines is to diagnose someone with kidney disease, we look at GFR and we look at a UACR, a urine albumin creatinine ratio, formerly known as a microalbumin. If that UACR is 30 or greater, those folks have kidney disease. It is a marker of inflammation in the kidney. So either one of those people, a low GFR or a positive UACR, is going to be a patient who will qualify for this medication if they've got diabetes. So the GFR determines our starting dose. We bring them back 4 weeks later, and it can be dosed with or without food. It can also be crushed in people who have difficulty swallowing pills. What determines if we push the dose or can keep them on is their potassium. Just like with the MRA drugs, hyperkalemia is the biggest side effect. And in this drug, we see it at about 18%. So we want to check potassium. If that potassium exceeds 5.5, we're going to stop the drug. We can potentially re-challenge them once it drops into a normal level. But a potassium of under 4.8, we're going to push them to the 20. So this is what determines how high we're able to get them. The biggest side effect is hyperkalemia. We're going to monitor that at 4 weeks, and then we're going to monitor it every 6-ish months while they're on this drug. And it met its primary endpoints of reducing the progression onto end-stage kidney disease. It also met its primary endpoints of reducing cardiovascular death, stroke, non-fatal MIs, non-fatal stroke, and hospitalizations for heart failure. This drug is also a CYP3A4 substrate, and as a result, we want to avoid those strong 3A4 inhibitors. So if I've got a patient on finerenone and I need to give them Paxlovid for COVID, I need to hold this drug. Look at what it does. That drug, like ritonavir, increases the area under the curve of finerenone by 400%. We're going to talk about that in just a second. So hyperkalemia is our biggest side effect. You also on this drug want to advise patients to avoid grapefruit juice. It's about 1 liter a day. 1 liter of grapefruit juice a day increases, is a moderate 3A4 inhibitor. It's going to decrease the clearance of finerenone by about 50%. I have patients in New Hampshire who come October 31st, they go to Florida. They don't care if they're on a ventilator. They are out of the cold. They never drink grapefruit juice in New Hampshire, but when they get to Florida, they're downing it. So atorva, simvastatin, and finerenone are drugs that we need to say you need to avoid grapefruit juice. If you want to eat half a grapefruit a day, you're going to be fine. But drinking that juice becomes a moderate inhibitor. So biggest side effect, hyperkalemia. This drug is around $600 a month. Questions for me? We've got about 10 minutes left, and then we're going to take our quick little break. But let me wrap up this first part. Let's move to infectious disease. Let's start with ritonavir boosted nirmatrelvir. You know of this as Paxlovid. This is now FDA approved. Molnupiravir is not FDA approved. It is still EUA authorized. And I do believe probably at some point, molnupiravir may go away. I think it's on the market right now because it's an alternative as an antiviral for people who can't take this because of the drugs that they're on, the interactions, and it's better than zero. But I do believe at some point that probably is going to go away. So let's talk about ritonavir boosted nirmatrelvir. This drug is approved for people with mild to moderate COVID-19, and it can be also used in children 12 years of age and older, provided that they weigh at least 88 pounds or 40 kilos. What I want you to do in your handout is I want you to cross out the word positive. The CDC says patients no longer have to have a positive test in order for us to start an antiviral. You've all seen patients. They've tested themselves 72 times with at-home tests. We test them in the office. I know they've got COVID. They can't smell, they can't taste. It's classic COVID. And yet I can't get a positive test. Those folks can still be treated with an antiviral, says the FDA and the CDC. They also only want us giving this product to people who are at high risk for progression on to moderate to severe disease, hospitalization, or death. So I have people 25 call up and say, I want you to give me Paxlovid. They have no health issues whatsoever. I'm not giving it to them. My concern, like all of our concerns, is what is going to happen with drug resistance. If it is being overused and used in people who don't necessarily need it, is it going to be beneficial over the long haul? And that concerns us all. So how does this work? Well, nirmatrelvir is a protease, a SARS-CoV-2 protease inhibitor. So it blocks viral replication of SARS-CoV-2. Why did they add the ritonavir? For its interactions. Because ritonavir, being a strong 3A4 inhibitor, is going to decrease the body's ability to break down the nirmatrelvir. That's why we call it ritonavir boosted. The ritonavir makes it difficult for the body to break down and raises the level of the nirmatrelvir, making it more effective. So to get that emergency use authorization, the first trial they did, phase 2-3 double-blinded placebo-controlled trials, patients had to have confirmed diagnoses of COVID. This was back early in the pandemic. And what they looked at was hospitalizations and death within 28 days after taking this drug, or comparing those to those who got placebo. And this is what led to the EUA authorization. 66 people were either hospitalized or died within 28 days in the placebo arm, 8 in the drug arm. And this was about 1,000 patients in each arm. So this is what led to its original EUA authorization. And now it's fully FDA approved. And if you go into the package insert, there are a number of other studies that have now been done to get the full FDA approval. We want to begin within 5 days of the onset of COVID symptoms. We also dose it with or without food. I've had patients say, if you dose it with lemonade, it cuts down on the dysgeusia. I've also had patients tell me, in fact, a nurse practitioner colleague of mine said to me, Wendy, here's what you tell your patients. When the bad taste in their mouth starts to go away, it means they're due for their next dose of this medicine. Because again, dysgeusia is the biggest side effect. There are two dosages, right? There is your standard 300, 100 dose. But if they have kidney disease, there is a dose reduction. There's a renal dose for this, and that is half the dose of nirmatrelvir. So it's 150, 100. And that is for anyone whose GFR is 30 to 60. So in that stage 3 chronic kidney disease. We do not have an indication at this time to use this drug in anyone whose GFR is under 30. There are studies ongoing to see if it is safe and what that dose would look like. But right now, if their GFR is below 30, it is not a drug we use. The only drug approved for people with GFRs under 30 to target COVID is remdesivir. Remdesivir is now fully FDA approved to be given to people on dialysis who have COVID to reduce their risk of bad outcomes. This drug has 650 drug-to-drug interactions. The ritonavir does. And of those 650, 250 are severe. Two of my favorite apps is the Liverpool Drug Interaction Checker. I don't know if any of you have used this, but it's been enhanced because of Paxlovid. It's called the Liverpool Drug Interaction Checker. There is an app you can download from the App Store for that. You can also do it online. I encourage the NPs in my clinic to use two different apps. I also use Hippocrates. I also have a Lexicomp app. But I can put in the drug interactions. I had a patient come in to me, huge risk for bad outcomes from COVID. She was on 11 medicines, 8 of which were antipsychotics, antidepressants, psych meds. I did her interaction check. It interacted with 5 or 6 of those meds, of which I had to stop them. It wasn't even like I could dose alter. These meds needed to be stopped. I said to her, COVID or no COVID, I am not stopping your antipsychotics. And so, and plus some of them, she was on 1 injection. I couldn't reverse that. So we went with molnupiravir, not as good, but better than 0. And so these are some of your interactions. The FDA has released a statement that the most reports that they're getting in terms of bad outcome are from patients on statins and patients on calcium channel blockers. Those are where we're seeing the bad interactions occurring. And although it may raise the levels of some drugs, it can also lower the levels of others. And a lot of our patients are on oral chemotherapeutic agents. So drug interaction checks are very, very important. So here are your adverse events. Dysgeusia is the big one. We're going to talk in the long COVID lecture about the impact of this drug in terms of reducing long COVID. We're also going to talk about what about using this drug in patients who already have long COVID? Is there benefit? And we'll talk about that in the next lecture. So it was about a year ago now that the World Health Organization and the NIH got together and said, for patients at high risk from COVID, there are 3 drugs we want you to consider using. And they ranked them. Ritonavir boosted NERM was number 1. Number 2 was remdesivir. And then they stated, if you cannot use any of the top 2, this is your alternative. And this is molnupiravir. This is still not FDA approved. It is EUA approved. This works a little bit differently. This works by embedding an error in the genetic sequencing of the drug, which then causes a fatal error in the drug. I meant the virus, causes a fatal error in the virus such that it cannot replicate. Some of you may have seen a study that just came out that raised question about, because it's embedding an error in the genetic sequencing of the virus, is it contributing to some of the mutations that we are seeing in the world of COVID? And none of us know, but there are studies ongoing now to look just at that. Is it contributing to any of these mutations? This drug is not approved in children. This is adults only. It's only an outpatient drug. They studied this in 1,400 patients, looked at the same outcomes, hospitalization, death, through day 29. And you can see that the numbers of placebo are higher than the numbers with molnupiravir, but it's not as robust as what we saw with ritonavir. It also comes in a pack. It's 5 days, should be started within 5 days. But here is an important takeaway right here. This drug should never be given to a woman who could become pregnant or is pregnant. In the trials, when it was given to pregnant rats, there were significant teratogenic impact. And in fact, the recommendation is now, do not give to a woman who has not been confirmed to not be pregnant if she's of childbearing age. Men who take this drug should wear condoms for 3 months after they take this medicine and should avoid conception for 3 months. And women should be advised not to become pregnant within 4 days of taking the last dose of this medicine. It's actually really well tolerated. People do fairly well from an adverse event perspective. It hasn't been studied in end-stage kidney disease or moderate to severe liver disease. And my last slide before I let you go on your break is there was a study that was published. It was called the Panoramic trial. It's a randomized controlled trial. They had 2,600 patients. By the way, these patients had already been vaccinated against COVID. They then got COVID. They were at high risk for developing moderate to severe disease or being hospitalized or dying because of their age, their comorbidities. And they gave them molnupiravir versus placebo. And at the end of the day, it didn't reduce rates of hospitalization, nor did it reduce death. What it did do was reduce primary care services, reduce viral load, meaning maybe less transmissible, and shortened recovery time. But there were no improvements in those serious adverse events. So stay tuned. Not sure where this is going to go, but let me stop here and ask you, do you have comments or questions for me before you run out to your break? Take a 10-minute break. I'll see you. We'll do part 2 for the next, in the next hour, 20 or so. Enjoy your 10-minute break. Andy, will you bring up part 2 for me?